Welcome to the Nexus. In this video, we are going to talk about atrial fibrillation, commonly known as AFib. To understand this, I will need to introduce to you a new term, an arrhythmia. What is an arrhythmia? The heart rate is usually 60 to 100 beats per minute, right? If the heart rate is less than 60, that would be bradycardia. And if it's more than 100 beats per minute, that will be tachycardia. Next, I'm going to show you an ECG, right? This is a normal ECG showing electrical conductivity in the heart, right? So you can see all the waves present here. The other waves are that's where I want you to look at, right? So this is normal, and this is like this distance from R to R to R is equal here. That's the normal ECG. If you look here, is equal, but this distance is too small. It means the heart rate is too fast. That's tachycardia. And like on the contrary, you can look at here and see the distance is there is a large distance from R to R. So this is bradycardia. The heart rate is slow. The other thing is regularity, right? So you can see this distance is same as this distance and same as this. That's normal. It's regular heart rate. But if you look here, this is small. This is even large, medium, regularly, irregular. For AFib, I will remind you about this again. Now, atrial fibrillation is actually a tachycardia, right? So let's look at tachyarrhythmias, right? So these can be divided into two main groups. The supraventricular tachyarrhythmias, that's above the ventricles, and the ventricular tachyarrhythmias, right? So the supraventricular tachyarrhythmias can be classified into two. Those ones which require atrial tissue, they are called atrial tachyarrhythmias, and they include atrial fibrillation, what we are talking about here, atrial flutter, and atrial tachycardia. And these ones, they require the AV node. They are called AV junctional tachycardia. All right, you have nodal re-entrant tachycardia, accessory pathway, etc. But now just focus on atrial fibrillation, right? So atrial fibrillation is a most common sustained arrhythmia. What is a sustained arrhythmia? It is an arrhythmia that lasts for more than 30 seconds. The exact cause of atrial fibrillation are unknown, but several risk factors have been identified. The first group is cardiovascular risk factors. These include advanced age, hypertension, diabetes mellitus, smoking, obesity, sleep apnea. The next group is intrinsic cardiac disorders, and this include coronary heart disease, valvular heart disease, especially the mitral valve disease, congestive heart failure, pre-excitation tachycardia, that's Wolff-Parkinson-White syndrome, sick sinus syndrome, this is a combination of tachycardia and bradycardia, cardiomyopathies, and pericarditis. The next and last group in this case is non-cardiac disorders, and these disorders include pulmonary diseases like chronic obstructive pulmonary disease, COPD, pulmonary embolism, pneumonia, hyperthyroidism, catecholamine release, and or increased sympathetic activity, right? So this increased sympathetic activity will cause stress, right? And this stress can be like as to sepsis, hypovolemia, post-surgical state, especially after cardiac surgery, hypothermia. Next is pheochromocytoma. This is a tumor of the adrenal medulla, right? If you remember the adrenal gland, the medulla produces catecholamines like epinephrine or adrenaline. Next is cocaine and amphetamines. Electrolyte imbalances like hypomagnesemia, hypokalemia, also risk factors. Drugs like adenosine, digoxin, holiday heart syndrome, right? So this is an irregular heartbeat classically triggered by excessive alcohol consumption, but also sometimes by moderate alcohol consumption, stress, dehydration, and lack of sleep. Chronic kidney disease is also a risk factor, right? There are a lot of risk factors, but the most important ones can be remembered by the mnemonic parasite. Parasite for pulmonary diseases, anemia, rheumatic heart disease, atrial myxoma, sepsis, ischemia, thyroid disease, and ethanol for alcohol. Parasite. Pathophysiology, right? The effects of atrial fibrillation. The atria contract rapidly but ineffectively and in an uncoordinated fashion. This will lead to stasis of blood, and if the blood is stasis, this increases the risk of thromboembolism, and those thrombi can go to the brain and cause a stroke. Irregular activation of ventricles by conduction through the AV node, this will lead to tachycardia, right? So if you look here, this is an atrium, and this is a thrombi here. Is a thrombus in the left atrium. Clinical features of AFib. Most affected individuals are asymptomatic. Less commonly, affected individuals may develop symptoms of arrhythmias such as palpitations, dizziness, syncope, fatigue, and or dyspnea. Tachycardia with an irregular pulse. Remember, irregular, right? So in this case, it's pulse. AFib. Complications of long-standing atrial fibrillation. The complications include acute left heart failure leading to pulmonary edema, thromboembolic events leading to stroke, transient ischemic attacks, renal infarcts, splenic infarcts, intestinal ischemia, acute limb ischemia. And another life-threatening complication is ventricular tachycardia. Diagnosis of atrial fibrillation, right? So firstly, we need to confirm atrial fibrillation using ECG. Perform TTE, that's transthoracic echocardiograph, to assess cardiac functions and to rule out structural pathology. And last but not least, we need to investigate the underlying cause. Right, so this is the conduction system of the heart, right? So probably know this already. This is SI node, AV node. This is the bundle of His, which will branch into left bundle branch and right bundle branch, and the ends here are fibers called Purkinje fibers, right? So in atrial fibrillation, there is like this massive and ineffective contraction here, right? Like boiling, like let's say the blood will be static and boiling inside here because of abnormal impulse. So this is the normal heartbeat. You can see irregular, I mean it's regular heart rate, right? You can see it's same here, but here firstly there is tachycardia, and there is also irregular, like these distances are different, is irregular, and most of them are small, that's tachycardia, right? So the characteristics of ECG findings in AFib. Firstly, the rhythm is irregular RR intervals, and in rare cases they may be regular if there is complete AV dissociation. Next is the rate, right? So the heart rate is actually variable, but tachycardia is common, as I just said. And in this case, the atrial rate is more than ventricular rate. Next are the P waves. The P waves are indiscernible. Fibrillatory waves, or F waves, I will show you these, are seen instead at a frequency of 300 to 600 per minute. The PR intervals are not distinguishable. Next, the QRS complex. This is typically narrow, like less than 0.12 seconds. And broad complexes may be seen in some situations. For example, aberrant conduction, e.g., bundle branch block or pre-excitation as seen in AFib with of Parkinson-White syndrome. Complete AV block with a ventricular escape rhythm can also cause the broad complexes. Right, so this is an ECG showing AFib. Right, so firstly, if you look at the rhythm here, it's irregularly irregular. Right, example of RR intervals, which are regular, indicated by red arrows. You can see here, this is actually, this distance is larger than this. It's irregular, it's not constant. Average ventricular rate approximately 84 per minute. 14 QRS complexes can be seen on a 10-second rhythm strip. Again, there are no discernible P waves. Narrow QRS complexes, and examples indicated by green lines. You can see green lines. The cardiac axis is normal. Laboratory studies. Firstly, complete blood count. Right, so this is actually for assessment of anemia and signs of infection. Basic metabolic panel. This will look at the serum electrolytes like sodium, potassium, magnesium, and calcium. This is to identify the electrolyte imbalance as a risk factor, right? Remember, serum glucose is actually to assess for hyperglycemia. Blood urea nitrogen, serum creatinine. This is actually to identify chronic kidney disease. Thyroid stimulating hormone, free T4. This is to screen for hyperthyroidism. Liver chemistries to assess for liver disease. HbA1c. This one is to assess for diabetes. To assess the complications and the underlying etiology, we can also test for troponin, for MI, brain natriuretic peptide, D-dimer levels, like if patients have risk factors, for example, deep vein thrombosis or clinical features of pulmonary embolism. Serum toxicology, this is basically for alcohol, digoxin, and or urine toxicology for cocaine, amphetamine, right? So these are the risk factors I talked about in the beginning of this video. Right, next, transthoracic echo, right? This one is indicated in all patients with a new onset AFib to assess cardiac function and rule out underlying structural cardiac disease, for example, mitral valve stenosis. The findings in AFib. The heart may be structurally normal, that's more common in young people. The left atrial thrombus may be visible. Atrial enlargement, chaotic atrial movements that are not coordinated with the ventricles. Chest X-ray, right? So this is indicated to evaluate for pulmonary disease or heart failure, and the findings include signs of heart failure, for example, cardiomegaly, enlargement of the heart, and signs of pulmonary edema, as you can see here on this X-ray. Signs of an underlying etiology such as pulmonary embolism, pneumonia, or COPD, hydrostatic pulmonary edema, right? So this is a COPD, hydrostatic pulmonary edema, right? So here you can actually see cardiac silhouette, right? So the cardiac silhouette is enlarged. And other things you can identify here. I'm not going through everything, right? So you can pause and read through this and understand. Next will be rhythm monitoring. So you have the following options. In inpatient, there is continuous cardiac telemetry. In outpatient or ambulatory, there is Holter monitor, event recorders, loop recorders. Rhythm monitoring is indicated to assess whether rate or rhythm control measures are adequate. Also to evaluate for suspected paroxysmal asymptomatic atrial fibrillation, and assessment of relationship between symptoms and AFib, thus patient-activated event recorders. The findings are usually episodes of paroxysmal AFib, which may reveal additional arrhythmias, for example, atrial flutter. Right, we will talk about atrial flutter in this video as well. Other investigations include cardiac stress testing, right? So this is if underlying ischemic heart disease is suspected, or to assess the adequacy of rate control. Electrophysiological study. This is used if suspected pre-excitation, thus delta waves on ECG, or if there is suspicion of underlying supraventricular tachycardia triggering AFib, or to distinguish between ventricular tachycardia and atrial fibrillation with aberrant conduction. Sleep study, right? So this one is definitely for obstructive sleep apnea if we're suspecting it. Management. So in management, there is rate control, rhythm control, and anticoagulation, right? So rate control is to control heart rate, and ideally we need to control it to somewhere less than 110 beats per minute. And rhythm control is to restore the sinus rhythm. Anticoagulation, we need to reduce the risks of stroke and other things. Right. Okay, so let's start with rate control. Right. So this rate control, we need to slow AV node conduction. We can use beta blockers, usually beta 1 selective agents like metoprolol, atenolol. In hyperthyroid patients, we can use propranolol. This actually reduces those palpitations. We can also use calcium channel blockers like verapamil, diltiazem. Digoxin, we can use it because it increases the parasympathetic tone of the heart, thus decreasing the heart rate. Rhythm control. Next, the goal is to restore the sinus rhythm. We can use cardioversion, right? It can be electrical or medicinal, right? So electrical, it can be synchronized or unsynchronized. So in this case, if we deliver synchronized shock, right? It's synchronized because it comes at the time of QRS complex. To do this, we need to administer an anesthesia and deliver electrical shock to the heart. And in this case, all myocytes are depolarized, and usually the sinus node first repolarizes or depolarizes. Right, you need to know that you can't cardiovert a patient when he or she is awake. Anesthesia first. Anesthesia first. Do not do this to a conscious patient. Right. Next, rhythm control, we use antiarrhythmic medications administered in conjunction with cardioversion. We can use them before or after. Right. Firstly, there are class 1 drugs like flecainide, propafenone. Class 3 drugs like amiodarone, sotalol, and dofetilide. Next, this one is actually anticoagulation. We need to prevent stroke, right? So firstly, there is warfarin, and this one requires regular INR monitoring, and the goal is usually 2 to 3. We can use rivaroxaban, apixaban, right? So these are factor 10 inhibitors. Dabigatran is a direct thrombin inhibitor. Aspirin, right? Aspirin is actually less effective. It's only used if the risk of stroke is very low, and we need to know that aspirin is also it increases bleeding, right? So we use it if there is a less risk of bleeding lesser risk of bleeding. Right. Next, how do we know that the patient need anticoagulation? The need for anticoagulation should be considered in patients with any history of atrial fibrillation, not just if they are in AF currently. That is, the following groups should be assessed. 1. Symptomatic or asymptomatic paroxysmal, persistent or permanent atrial fibrillation, atrial flutter, a continuing risk of arrhythmia, recurrence after cardioversion, back to sinus rhythm or catheter ablation. The NICE guidelines suggest using a CHA2DS2-VASc score to determine the most appropriate anticoagulation strategy. Right, so let's look at this score. Right, so C4. Okay, I'll just read through and the points. Right, so firstly is for congestive heart failure. 1. Hypertension over 140 per 90 millimeters of mercury is 1 point. Over 75, 2 points. Diabetes, 1 point. Prior transient ischemic attacks or stroke is 2. Then vascular disease like MI or aortic plaque, etc., is 1 point. Age between 65 to 74 is 1, and sex category female, 1 point. Right, so if the score is 1, 0 for male and 1 for female, the risk is low. Therapy, no anticoagulation therapy. If the score is 1 for male, is moderate risk, and oral anticoagulation should be considered. If the score is 2 or greater, it means there is high risk, so oral anticoagulant is recommended. Right, so anticoagulant regimen options in atrial fibrillation and atrial flutter. Firstly, there is vitamin K. It is indicated in valvular AFib, patients with non-valvular AFib with either severe hepatic dysfunction or advanced chronic kidney disease. Specific considerations, right, so vitamin K antagonist requires bridging with heparin when given in acute stroke or prior to unplanned cardioversion, and it should be avoided in pregnancy, right? So warfarin in pregnancy should be avoided. Direct oral anticoagulants, right? Is first line in long-term management of non-valvular atrial fibrillation. Anticoagulation prior to immediate unplanned cardioversion. We need to avoid this during pregnancy and may not be suitable in severe renal impairment. Examples or options include direct thrombin inhibitors like dabigatran, factor 10 inhibitors like rivaroxaban, apixaban, edoxaban. Heparin. Right, so heparin is good in pregnancy and anticoagulation prior to immediate unplanned cardioversion. Right, in renal impairment, use low molecular weight heparins with caution. Options we have is unfractionated heparin, low molecular weight heparin like enoxaparin, dalteparin. Atrial flutter. Atrial flutter is a supraventricular tachyarrhythmia that is usually caused by macro re-entrant rhythm within the atria. Etiology is similar to AFib, and there are different types of atrial flutter, type 1 and type 2. Not necessary. But yeah, they are necessary, but I'm not going to read through everything. I would like to indicate clinical features, and I'll also show you an ECG, right? So most patients are asymptomatic, and less commonly symptoms of arrhythmias may be there, like palpitations, dizziness, syncope, fatigue, or dyspnea. Tachycardia with a regular pulse, right? So in AFib, the pulse will be irregularly irregular. In atrial fibrillation, just it's a regular pulse. Diagnosis is similar to atrial fibrillation, and it is characteristic ECG findings of F waves, but these ones in capital letter like a SAW, right? So On ECG, the rhythm is regular and narrow QRX complexes. The rhythm may be regularly irregular if atrial flutter occurs with a variable AV block occurring in a fixed pattern like 2:1 or 4:1. Sawtooth appearance of P waves, thus identical flutter waves, F waves. You see this F in capital letter in atrial fibrillation is usually written in small letter. So they occur in sequence at the rate of approximately 300 per minute, right? So you can see here the atrial flutter, right? With an explanation, you can pause and look at this ECG. Treatment is same as atrial fibrillation. In rate control, it's more difficult to achieve in atrial fibrillation than in AFib. Rhythm control, we get better results and lower recurrence compared to AFib, and catheter ablation may be the most effective rhythm control strategy in atrial flutter. The same parameters for anticoagulation in atrial fibrillation are recommended. Complications of atrial flutter frequently degenerates into an atrial fibrillation and one-to-one conduction leading to life-threatening ventricular tachycardia, right? So this is bad, can lead to sudden cardiac death. Thank you so much. If you like this video, please give it a thumbs up and do not forget to subscribe.